Thank you,
So I'd like
everybody.
to invite you all to turn your videos on for the Q&A portion, if that's okay.
And
Dr. Steinberg's going to ask the question.
Well, but we've run out of time. So how much time do we have, Stephanie, for our Q&A?
If everybody could do maybe 5 minutes, we could just get a couple of questions in there. Is there anything specific that stands out? I do have a quick question.
Yep.
You mentioned that occasionally the upper tract might also be seen in the second kidney. Is there any kind of recommendation on when you can start treatment on that second kidney? Do you do them both at the same time? And how often does that occur?
Jen, why don't you handle this for us?
Yeah, so to have what we would call synchronous tumors, where you have tumors in both kidneys at the same time, is very rare. That's probably maybe somewhere with 2 to 4%. And I think, you have to take your time to figure out, does one kidney have low grade and the other kidney has high grade? And if they both have high grade, you may end up treating them at the same time, and even with the low grade. But it's a very complex issue depending on, is the tumor in the ureter or is the tumor up in the kidney? Is it low grade or is it high grade? And are these patients able to have what we call systemic therapy, like an immunotherapy? Because there are options in that realm for upper tract urothelial carcinoma as well.
Thank you. Next question, anything? I know one of the questions that was sent in was talking about recurrences. Are they closely genetically related? Are recurrences daughter cells of the original tumor? Or are they new tumors arising in the urothelium that has a field effect? So clearly the person asking this question has done their reading. Serena, maybe you could answer this question. It's the question from Neil Kurtz on the chat.
Yeah, so this is from an academic perspective, this is something that a lot of people have had an interest in. And so as it turns out, we can't say for sure that they are daughter cells or clones, as we say, but generally the data seems to show that most of them are. They're very similar in terms of their different mutations. And the subsequent recurrences that occur, whether they're upstream or downstream, all seem to be related. We actually just finished up a study looking at synchronous disease as well as metachronous, or metachronous meaning occurring at different points in time. And so we looked at those who had bladder cancer first and then developed it in the upper tract, and then those who had it in the upper tract and then lower tract. And what you tend to see is that they have the initial tumor and the subsequent recurrences all have the same molecular subtype, and then all the subsequent recurrences seem to basically maintain that subtype as well. The one more intriguing finding was that patients who developed bladder cancer first had this, what we call a basal subtype, and the upper tract recurrences were basal usually also. On the other hand, any case where the upper tract was involved first or simultaneously, those were what we call the luminal subtype. And then all the subsequent recurrences were luminal also, even if they occurred in the bladder. So that, I think, is a bit of a novel observation, and we are in the process of getting that paper published.